Okay, so welcome everyone. Um, Welcome to our workshop. I feel like I've been waiting to do this workshop for the last 20 years. My interest in pain really started. I went to a conference for physical therapists about 20 years ago when I was a student, and I heard the people from the NOI group speaking about pain. And it was really interesting because at that same time, I had a wonderful mentor and teacher, our orthopedics instructor, who warned us. He said, "We don't know that much about what causes pain right now, but what we do know is that is essentially that, don't make goals on it." He's like, "I've been a therapist for 20 years at this point. Try not to make any goals surrounding pain." So I always took that to heart. So I just wanted to thank Steve Furtick. I wanted to thank the scientists and clinicians at the NOI group. They are in Southern Australia. They are the only university right now that is doing education for clinicians specifically in the field of pain science. So what that means is most of your physical therapists, most of your nurses, your medical doctors, unless they are going to that particular education, pursuing that particular education, they might not be learning modern pain science. They're not learning it at the level of their education. Kind of mind blowing. So let's start talking about pain. And this is an image Andy took when he was doing some work for the movie Ringo. So beautiful. So when I think about orthopedic prevention, which is really my intention in doing practical strength, is to provide a way for people to get out ahead of potential breakdown and suffering in their bodies. Then I sort of think about it in these three ways. I kind of think about orthopedic prevention, preventative medicine as an umbrella. And then with under that umbrella, what I'm thinking right now, this time, 2024, is that addressing the science of pain, addressing the science of biomechanics, and that obviously includes grading movement so that we're not doing movements that we're not strong enough for. And then understanding exercise physiology a little bit, just the nuts and bolts. What exercises grow muscle and adapt muscle and tendons specifically, or muscle and bone specifically? So these are sort of the three things that I'm trying to address in our practical strength class to varying degrees of success right now. But pain science is such an important piece. I tend not to do it in the foundations class that I teach because I'm really working on these other two levels at first. I find what you're going to find in pain science is that it's actually extremely complex, extremely kind of nuanced, and we want to approach it in a way that's sort of friendly for all of us so that it doesn't get our head spinning too much because it's already a little bit of a mind meld. So the objectives of my workshop today are pretty straightforward. First thing we're just going to consider, is pain real? So I want everybody to just take a breath and just reading these words on the screen and just think about any time that you've had in your life when you've been experiencing pain, and has that pain been real? And we're going to look into this in just a little bit. We're going to explore the model of pain that is used in modern science. And this is probably the biggest sea change for us. I know for me as a clinician, this was maybe the hardest bit to wrap my head around. So just consider as we get close to that, how that exploration feels. We're going to explore if our images are good, or our findings on our MRIs and our X-rays, if those are a good correlation to how we feel in the body. And we have a lot of information and evidence on this. And then identify the underlying mechanisms of pain as well as the complexity of pain. That's really important. And then we'll get into the safety and danger messaging. We'll do this after we do some questions and answers, and reflect on actions, like direct actions. I like everything to be practical. So I called practical strength, practical strength. I like actions that I can take in this moment. So we'll check out some actions we can take. And really, I hope that our consideration of, let's see, this piece, the underlying mechanisms and complexity of pain, and number 6, I hope we can get into that in later presentations or later education opportunities. So first, just consider, is pain real? Is the pain that you have in your body real? Has it ever been fake? Never, right? Pain is always real. So you might have a friend that has the exact same medical diagnosis that you have, maybe even the exact same degree, but that person will experience that in their body differently. And what I hope to achieve in this hour together is that we start to get a sense of why that might be. All of our pain is very personal, it's very real, it's very normal. Not one person probably goes through this whole life journey without experiencing pain unless there's some sort of abnormality or some sort of change in their body. And what we're going to find out is that pain is our protective mechanism. And so, in the absence of pain, things get kind of dicey, right? No one else can know what our pain exactly feels like. And also, we can't know what other people's pain feels like. So why is it so crucial to talk about pain? Why am I so excited about this? Because learning about pain is actually therapeutic. It's like not the only therapeutic intervention. And in fact, what the literature is finding is that when we pair pain education with movement education, which is what we're doing in practical strength, that's actually what has the largest impact for people on resolving long-term pain pathways. So, learning about pain is super therapeutic, not just for ourselves and our own bodies, but it's really therapeutic for the practice of medicine. And this is there's kind of a little bit of stopgap around this right now. And so it's beneficial for society at large because the more that pain levels can reduce, the more people can get off of opiates and things like that, which can be really unsafe for them to take long term. And I want to just take a moment to start to distinguish here. A lot of the pain that we're going to be speaking about is pain that's been going on longer than 6 weeks. So, or longer than 12 weeks. It starts to move into a different field. And we're going to understand that a little bit in this lecture or this education experience because it changes some of the things going on inside of our body. And we've mostly had a lot of healing of tissues by that point. Becoming well educated in pain is such an important start for experiencing less pain in our own bodies. So, okay, I think this is the biggest game changer. And if I only had to have one slide in this whole workshop, this would be my whole slide. This is a wonderful drawing from the NOI group. Our current model of pain that is used and educated on in all of the leading medical institutes in the world outside of Southern Australia is that this Cartesian model of pain, where we have an injury or tissue that is unhealed, and that sort of like rings a bell in us, and that creates pain. And sometimes this used to be instructed back, 100 years ago when I went to school. Some of our instructors would say, so you have these danger receptors in your body, or excuse me, pain receptors, right? At the level of the neurons, the little sense receptors. And when those pain receptors are stimulated, pain travels on a specific pathway up to the brain. Some of you, if you went to school a long time ago, like I did, might have even learned that. But what we found out is actually that's not true as neuroscience education developed and expanded. And we'll talk about some of the basis of that. And so we had to kind of come up with a novel model of pain. Okay, so if pain isn't something that's like ringing a bell, it's not this model from the 1400s where it's always accurately reporting on what's going on in the body. And I should say, maybe it's always reporting on something, which we'll get into. But actually, pain is a confluence of all of these different inputs. It's never just what's going on in our tissues, which I consider the biological, or what's going on in our genetics, what's going on at our cellular level, what's going on at the level of our tendons and muscles and bones, right? Tissue pathology, inflammation, excessive load. But it's actually related to our beliefs and thoughts about our body, our knowledge about our body, some predictive thoughts we might have about our body, feelings and actions, things that healthcare providers say, things our society and culture says about our bodies. All of these actually come together like this beautiful Venn diagram. And we're going to see that this like whole person experience is what dictates the felt sense in the body. And it's really important to start to understand that we don't have pain receptors, we have danger receptors. And in the presence of enough danger, and danger could come from any one of these spheres, in the presence of enough danger, the brain will manifest pain. And the pain that is created is always at that level of the brain, not below, not at the spinal cord, not out at the fingers, right? It's always central because it's an output. Okay, that might seem a little bit complex right now, but just start to consider what I want in this slide is for each of us to start to consider what have my care providers told me about my issues. That's really important. What have my genetics or how much do I attach my outcomes to my genes, right? It's just a really interesting way of looking at it. So we're going to keep on this pathway. This is the modern pain science model. It has moved beyond just looking at a biomedical model. And so it includes our psychology as well as our sociology. It's very important. Biopsychosocial is what this pain model is called. And this is really well evidenced in pain science. This is where pain science has been in the past 20 years. It has really disproven this biomedical model. And this is especially sort of fleshed out or seen in the clinic by this concept. So, how well does images that are taken of our body relate to how we feel? And it turns out not very well. There's not a high correlation between what we see inside somebody's body and what they feel. And there's been a whole lot of different examples of this. And I'm going to give an example first of something that happened to me as a clinician. I had a wonderful patient who I saw, I think this is my first year of practice. If those of you are clinicians, you know you're kind of hit with everything. And my first year of practice, one of my patients was this really strong, big construction worker, and he had this intense shoulder pain that would happen only when he slept at night with his arm overhead. Okay, so I thought, well, he's probably getting some impingement, the bones are maybe compressing on the rotator cuff or cutting off blood supply during the night. I thought all these biomedical things, right? Because that was my training. And I said to myself, I am going to train him to sleep differently. And no, that didn't work out because a lot of sleep training doesn't work with adults. And he kept, meanwhile, working in construction, and he was a cabinet maker. So he would lift. He said, I can lift 100 pounds, no problem. I can work for 8 hours with my arms overhead, no problem. None of that hurts. And so in my mind, I was thinking, gosh, there's just this fiddly thing at night. And I only thought of like the biomedical contributions, and I thought it was probably tiny. So after I think 6 weeks or 8 weeks, as a clinician, if somebody's not making progress or not having a change, we tend to refer them back to their provider. It's really important that you guys know that. You don't want to linger with a PT for like years, right? Feeling the same way. So this guy's felt sense wasn't changing, so I referred him back to his orthopod. And the orthopedist took an image, an MRI of the inside of his shoulder. And I don't have those results, but just to kind of verbalize, you guys, it was the full catastrophe of shoulders. It was like bone spurs. It was all the rotator cuffs were no longer connected to their insertion point. It was the long head tendon of his biceps was no longer connected. The cartilage ring of the labrum was no longer connected. And he had severe degenerative joint changes. Now, his subjective was so minimal compared to the findings on his MRI that my mind was really kind of blown. And all those things that my teacher had said to me back in school started to really resonate with me. If our images aren't a clear indicator of what we can expect to find inside, what is? What can explain that? And another example of this is from this article by Brinjikji, and this was done in 2015. I have this up for one of our references. This should actually say 2014. Brinjikji is a radiologist and has done quite a few reports, but I'll modify that number. I think I have the date modified in my references. And Brinjikji looked at essentially all of these research articles, did this meta-analysis of all these research articles of radiology imaging reports. And the radiology and imaging reports were done on people that had never experienced back pain, no back pain in their lives, which is pretty remarkable given that 80% of us experience back pain at some point in our lives. So it was from the ages of 20 all the way up to people in their 80s. And what they did, they had like, I think 3,000 subjects that they got to look through, 3,000 radiology reports. And they matched on those radiology reports of all the people who'd never experienced back pain in their life, how many of them had actually orthopedic findings. And here is the result of that research. So again, the numbers were over 3,000 images were looked at. The image findings, the age of the people that were imaged is in this line here. And then the types of orthopedic findings that the image conveyed, this was a spinal image, an MRI, or all of these potential findings. So like of 37% of asymptomatic people in their 20s, 37% of them had a disc degeneration that was present, okay? Now look over here at people as they age in their 70s and 80s, how common degeneration is, but again, no symptoms in these people. Isn't that fascinating? And notice the difference in the percentages. And so what you might say is that, again, as we age, we have maybe a greater likelihood if we've never experienced pain of continuing to not experience pain. And then another thing that I think about with the age, especially as an orthopedic provider, is are these changes like normal, expected changes that occur with aging? Are they like wrinkles on the inside that we can sort of expect and anticipate? And I also think that pathology, or this is a huge sort of question for me, like orthopedic pathology probably should be treated differently when people are age 50 and above because of these findings, rather than how they're treated in their 20s, 30s, 40s. That makes sense? So start to question, is cartilage thinning really just kind of like a wrinkle on the inside of your body that we can expect to see? It doesn't make sense to think about orthopedics the same in our 20s as we do in our 80s, just like we don't think about retirement accounts the same in our 20s as we do in our 60s. We don't think about skin the same in our 20s as in our 60s. So kind of interesting. So what the heck is pain anyways? Okay, so if pain is not what I thought it was, which is this accurate reflection of what's going on inside, what is pain? Pain is actually one of our we have many, many protective outputs in our body. And the NOI group does this beautiful image. I have it coming up in just a little bit where we can look at some of those outputs. And it's important to think about the nervous system as having inputs, right? So inputs are interoception, if people know that word. That just means like our ability to feel what's going on inside of our body. That's an input, right? Our visual field is an input. Our auditory field is an input. There's many different inputs. And outputs are things that we generate up here, pointing to my head, up high at the level of the brain and the cortex, that attempt to protect us. So pain is just one of many protective outputs, options that our body has. And then we're going to do a little anatomy check-in. So again, I mentioned this before, and I want to mention this again, that all of our sensory fields, right? We have like the retina in our eye that is taking in information through our bodies. We have all these beautiful receptors sensing chemistry, sensing pressure, sensing changes in position, light touch, vibration, strong pressure, sharp touch. And it's really important to know that what those senses do is in every classification of sense we have, when there's enough of an input, we can have a danger message that is detected. So if you go to stick your hand in a fire, that flame is too hot, your little thermoreceptors that sense temperature will go, there's danger. And they'll send a danger message up the nerve up the spinal cord, up into the brain, and your brain will generate an output, which is probably pain, so that you take your hand away from that flame. It all happens very quickly. Pain involves distributed brain and nerve activity. What does that mean? Distributed just means large. So it doesn't happen in a particular area of the brain. I've heard sometimes people talk about pain being manifested, just in small areas and looking at activity in little areas. But actually, when you study this, pain actually happens at many different levels. And we're going to see that the many levels of our nervous system change in response to pain. So think about the whole of the brain like an orchestra working together to manifest this output of pain for you to protect yourself. Really interesting. Not just one area. This is a little blurry. I'm so sorry, you guys. I'll see if I send this out. I'll send this out as an image when I send out the recording. So these are many different outputs that are possible. So we can have an output to pain, which is an immune response, right? Or to danger, which is an immune response. So we all know this from basic physiology, basic biology of viruses, right? We all just went through this big virus. Your body detects a virus and it launches an immune response, and that is a form of protection. We can have our bodies detect danger in our position, and our muscles can increase their tension, and our movement can change so that we try to create a protective output there. There's many different motor outputs. There are endocrine outputs that can happen, and endocrine system is our hormonal balance system. So we can change things like depression. We can start to feel depressed. We can have changes at the level of our gut. We can have reduced healing phases of tissue when the body detects danger. So all these different processes can happen because of this hormonal system. So pain is just one level of output that can take place, but actually many different outputs and many different systems occur ongoing throughout our life in the presence of danger in order to protect ourselves. That is our main goal, is to stay alive, right? And that's our brain's main goal, is to protect ourselves and to stay alive. So this is like a really basic way of looking at the neuroanatomy. I'm going to introduce this and a couple more slides, and let's take a break. So you'll see down here, let's start down here. Down here, think about this as the fingers. Think about this as, and this is actually already at the level of the spinal cord. This doesn't show all the way down. So you have nerves that run from the spinal cord all the way down through the legs, through the arms, through the whole of your body, into the organs as well that are sensing, detecting. They're in the walls of your arteries. They're detecting pressure, right? They're detecting changes. Let's take the common example though of heat, because that's a really easy one. So again, say you're cooking and you expose your right hand to some heat, then that thermo sensation of danger will travel from your finger all the way up to the spinal cord, and it will communicate. That message will at some point cross the spinal cord and then travel up. This is already parts of the midbrain, up, and then be received by different portions of the brain and different portions of your cortex. And then again, your brain can decide what to do with that. Your brain might go, oh, you know what? Trina's fingers just had a change in temperature. It's warm, but there's no danger. Just proceed as normal. But if my brain senses that this signal that's coming up actually is at a level, at a threshold that is dangerous, then my brain will go up, you know what? We got to change her movement output. We got to start swelling the inflammatory system. We got to create a psychology where she starts to be more mindful, fearful of this heat the next time that she cooks to protect her tissue. Okay. So the brain is receiving all of this message and inputting and creating an output in response to that input. And I just want to mention here that all of this is changeable. All of this is changeable. So in other words, if I take and expose my finger to heat every day, I do it every day, every day. I don't have skin damage. Say it's important for me. Say I'm a cook, right? Cooks do this all the time. You see them pick up stuff with their bare hands. I expose my hand to heat every day, every day. At some point, this system is going to remodel and go, you know what? There's no danger here. This is just the same thing this lady does every day. She's going to do it again tomorrow. She's going to do it again on Wednesday. So no danger message. The message will be sent like, yep, Trina's fingers warming up, but the level of message will be tamped down so that there's no response at the level of the brain to manifest pain. Fascinating. So this looks hardwired because of the red and green lines, but I just want to mention none of this is hardwired. And there's no pain detection system out here. Okay. There's danger detection. And the pain is going to be manifested at the level of my brain if I choose that it's important to have it. So this is another way of looking at that brain activity. So distributed brain activity can sound kind of complex, but all it means is that the whole of the brain, the whole of the cortex, and not just the cortex, different parts of the brain down to the cerebellum will be involved in this protective network, this protective output. And because nerve is like bone and it's very well vascularized, meaning it has so much blood flow going to it, it is so adaptable and plastic, meaning changeable through the whole of our lives, that what can happen is that these little networks that all ping, ping, ping back to each other, say this is my sense of heat, and it'll go from one area to another area where I'm all trying to process, what am I going to do with this message? Am I going to pull my hand away, or is this the same sort of change in heat that I felt on Tuesday? And we're having this pinging of information through all of these different areas of the brain. And this lends us back to the biopsychosocial model of pain. Because if pain were only being received, say, into the sensory cortex, and then back out, the response through the motor cortex, we wouldn't necessarily have like the social and psychological aspects of danger affecting us. But because of this distributed pattern of brain activity, because it's pinging around to all these areas are weighing in. So that, my prefrontal cortex or my sensory cortex might just be like, it's just a normal change in heat that Trina's experiencing. But my amygdala might have changed over time to be fearful based on past events of that pain. Say, maybe 2 weeks ago, I did the same thing, but I suffered like a third-degree burn and I wasn't able to cook for a long period of time. And my body manifested a lot of pain. And I had a lot of tissue damage as I was healing in that acute phase. Then my amygdala would weigh in more and manifest more pain and say, we got to have a stronger output. Okay. So again, it's like this beautiful orchestra all working together to process these incoming inputs. Any of us that think that our sensory system is giving us accurate feedback all the time about our world hasn't spent time in meditation. Because if you spend any time in quiet meditation, what starts to happen at some point is you start to notice all of this little chitter chatter between many different areas, and you start to realize how that is going on all the time in the background of world experiences. So it's kind of like we're always wearing filters that we see the world through. And this can happen with our physical bodies as well. Filters that we experience our injuries through, filters that we experience our aging through. When you're just getting started with learning this stuff, we had some really good questions off camera. Proceed slowly. This is just part one. This has been a 20-year exploration for me. This is a 50-year exploration for people like David Butler, who is some of the leadership in this content. So just go slowly. Okay. We just talked about differentiating between emotional pain and physical pain. I think it's really important to differentiate. What we're talking about is physical pain. And really, the type of physical pain that we're focusing on right now is physical pain that has been going on for longer than about 2 months, 3 months, longer than the time needed for tissue to heal. That's the kind of pain we're talking about. And this pain education is really helpful for people with intractable pain, like CRPS, which is chronic regional pain syndrome, right? Things like that, or complex regional pain syndrome. It's really helpful for that kind of stuff. Or if you've had pain that you think is from a disc injury that's 20 years old, or your discs have healed, 8 weeks ago, this is the kind of pain that we want to focus on. So it's a lot of physical stuff. Pain depends on the balance of danger and safety messaging because of what I just talked about at the level of the neurons. Okay. And this is really important. Like, so for people that live in, say, like south parts of Chicago or South Central Los Angeles, where they live in dangerous areas, they tend to have higher levels of pain, chronic pain persisting after phases of tissue healing, right? So after a bone has broken and healed, those folks that live in dangerous situations, social environments, conditions, tend to experience pain longer. When danger persists, many different protective mechanisms can start to get involved, and the level of them can start to get amped up. And it's like that. If you guys ever saw that movie Spinal Tap, it's like turning it up to 11. It's like turning up an amp, turning it up, or a volume knob. We're going to look at it that way. And then your body has to come up with novel ways. So that's when we start to maybe see gut involvement from the endocrine system. That's when we can start to see difficulty with wound healing at the level of the endocrine system, difficulty fighting off infection at the level of the immune system, right? So it's not just physical pain a lot of times. Physical pain is really our focus here. It can be a whole host of different outputs that start to get triggered. And this happens bidirectionally throughout the nociceptor is the danger receptor. From that very little thermoreceptor at my fingertip, all the way up the nerve to the spinal cord, at the spinal cord, all the way up the spinal cord to the brain. And I want to just show that image that I showed before, because what does it mean bidirectional? So when our signals start to get amped up, say I am a cook, I'll use that example like I used before, and I'm trying to make it. And I am scrappy. I am like living on next to nothing, right? I have to eat ramen noodles every night. I'm trying to make it as a chef. And I'm barely subsisting. And my landlord wants to raise my rent, and I can barely make my rent as it is right now. And I get a cut in my finger. And that cut in my finger travels, ascends up my brain. And my brain has all of the psychological and social information up there. If I don't, if I get this finger cut, I'm going to be out of work the next couple days. If I'm out of work the next couple days, this is going to influence how I can make money. I might be out of a job, right? I might be out of an apartment. So all the different ping ponging around my brain will happen to turn that danger signal up. Now it's not just the danger of the cut on my finger, but now it's the danger of my livelihood. It's the danger of my capacity to be able to be housed, right? So many different things. And I might have a greater pain output because of that. And that pain output happens at the brain, at the spinal cord, and it happens down here. So it doesn't just happen in this incoming way, but it also happens in this outgoing way. So the output will be turned out and the input will get turned up. So the likelihood of creating or manifesting pain gets higher and amplified overall. Okay. And this change happens in these really beautiful small ways at the level of the neuron, which it's too fancy for us to get into at this time, but there's actual cellular adaptations so that and then the next time I cut my finger, I might, even if I'm in a different place, I'm in a different phase of my career, I'm not going to get fired if I have to miss a few days of work, I have a more stable living situation, I still might have an overamped pain response because my nervous system kind of remembers the imprint of that last pain response where I needed that to protect myself. So danger related to protection, really, really, really important. And so this is really important for one of the ways in which we start to work on balancing our output, right? And this is so important for everybody because I think that this is probably like Stephen is on today. Stephen is a master in balancing safety as far as I'm concerned. Some people are, my mom is masterful in balancing safety, and I fortunately gleaned some of that from her. Some people are extremely like kind of either they developed it on their own or they inherited it. They saw other people doing it. They are masterful at safety messages, while other folks tend to kind of enhance danger messaging often in their lives, in their bodies, in themselves, in the way that they consider their place in the world. So this is a protectometer. This is sort of like a thermometer where you can start to check in. When I hear people say things about their body, like somebody just recently said, my neck is very fragile. So that understanding, that message for her, that belief structure starts to move that person up this level. It's a pretty big danger message. When a medical provider says to somebody, this is my least favorite thing that orthopedists say, you have bone on bone degeneration of your knee, right? Instead of saying maybe like you have 10% remaining cartilage and synovium at your knee to help provide you, you can stimulate those remaining cells to help nourish your movement there. But that you have bone on bone degeneration of your joint starts to move people, the believer, up this level of danger. I was helping with an occupational therapist. We were moving a patient just recently, and she said, you're going to hurt your back. And I was in a great biomechanical position, and I said to her, no, I'm not. I'm really in a great position. I'm super healthy. And so balancing this out in ourselves, in our lives, in our loved ones, knowing how much safety we're projecting in the world in ourselves and how much safety we're projecting among our loved ones is a really important thing. And this, I love this image from Bodily Relearning from Benjamin Boyd. This is a wonderful resource. Basically, all of the resources from the NOI group are all based on modern pain science that has come to fruition from tests, modeling, imaging of functional MRIs. Over the past 20 years, it's really important that our information is kind of modern. And it's interesting how also, I just want to say before we talk about some of this, I think that like John Kabat-Zinn came up in our break, and John Kabat-Zinn's work is sort of based on some basic, not basic, but like Buddhist psychology and Buddhist work. The Buddhist work around psychology, around sociology, reflects modern neuroscience. Like, I remember, in the 80s or 90s when there was this idea of moving stuff out of you. If you're angry, get it out of you by beating a cushion or hitting a punching bag. But actually, what we know about modern neuroscience is the more that you feel something, the more you feel it. So if you go and punch a bag and feel violent, or feel anger, the more likely you are to feel anger because the nervous system remodels all the time based on what you're experiencing. The more you look at the world and experience a sense of danger or interpret a sense of danger, the more those danger messages get ingrained and the more you see danger in your world around you. This is looking at that volume knob, thinking about our nervous system, about the level of our interoceptors, our little sense receptors, how we take in information at the level of our fingers, how we process information at the level of our spinal cord and at the level of our brain. We are all the time either upregulating that information or downregulating that information. And when we're downregulating that information, we're pretty chilled out, right? Just like in the protectometer. This is just another way of thinking about it rather than like a thermometer. This is a different visual. Here, our nervous system sort of like responding a little bit. And then a lot of us are walking around with our nervous systems like this, though, right? I'm concerned about all these different areas. I feel danger from all these different inputs. It's really incumbent on us to start to learn how to gently work with our nervous system and our brains so that we are seeing safety where it truly exists in the world. right? And for medical providers to be seeing this in our clients, right? Right now, I'm working with a lot of people, a lot of people experiencing homelessness. Their nervous systems are like this all the time, and so it's very, very, very hard then at that point to provide enough safety to move out of that. But all of us sitting here, and probably many people that can watch YouTube and things like that that have devices aren't in that same level of danger, but believe it or not, our nervous systems might not know that. That's why somebody in class once said the interoceptors never lie. And I was like, when you know the nervous system, you know that none of the nervous system is reporting necessarily on the truth. It's reporting on the sense that we use the most, on how we kind of guide our sensory system. And one of the biggest places where we can encounter this sense of plasticity, changeability, neuroplasticity is at the level of our homunculus. And we've known this for a long period of time that when people have long term pain, or like headaches were brought up, when people have long term headaches, these sensory maps on our brain change. I saw somebody yesterday who'd had an amputation, and I said, "Can you still feel your foot?" And she laughed and she said, "Oh my gosh, my ingrown toenail is still giving me pain." And we looked down and she had no foot. And she was great. She kind of laughed about it. But it's because the map on the brain still exists, right? And you can change, and we do change. And I think in foundations class, we experience this a lot. People will say, "Well, I haven't felt my neutral spine in my back before, so I don't know where that is in space. I don't know what it feels like to relax my pelvic floor." I think a lot of us have had so much long-term smudging in these areas, these maps, that we've lost our ability to maybe create movement in our big toe, to sense a different pathway here, to truly feel our knee. Things get smudged in this area so that like the head and neck will start to bleed into the belly. And then when I ask somebody to do like, to relax the pelvic floor or to move their big toe into the midline, they can't recall how to do it. It's all there. It's just that our nervous system is so changeable based on how we use it. So we want to start to be really conscientious about how we're using our nervous system. And that was something really beautiful that John Kabat-Zinn did in his MBSR work. He started to work with people to train them to notice patterns, habitual patterns of what we're noticing. This came out blurry, you guys. I'm so sorry. But maybe you could read this section right here. So as far as danger, safety messaging, this isn't psychological, okay? This isn't psychological. I know it seems like it. This is all about danger and safety. And the reason I'm kind of steering clear of psychology is because I'm not a psychologist. I'm not trained in that. If you're interested in more of the integration between psychology and pain, I would check out Rachel Zoffness. I have her up in our resources section. She has a whole great workbook that's sort of on cognitive behavioral therapy. But what I want to talk about is danger messaging that we receive and safety messaging that we receive, both from ourselves as well as from outside of ourselves. So things we hear, see, smell, taste, touch. So imagine for that person yesterday sitting in bed looking down at her foot and not seeing her foot present anymore. Think about what the sight of that must have been a tremendous danger message for that person. Things that we do. So things we do like surfing could be a huge safety message for somebody. Hiking could be a safety message for somebody. Doesn't have to be an action, could be cooking, right? Like I was using before. Things that we say, things we think and believe, places that we go, people in our life. People in our life is a huge one because we're constantly interacting with people and we're impacted by their senses of danger and safety. And many people are not working at the level with their safety and danger messaging. And so we might be kind of, I don't want to call it hijacked, that's too strong a word, but like kind of influenced by other people's danger messaging and then things happening in our body. I know it's getting close to 10 o'clock. I want to just finish up our slides before we go. So let's talk about actions. How do we take action to change how the body feels? And this can't just be done through changing how the biomedical process, right? Part of it is done through the biomedical process, like learning how to do lymphatic massage so you can take out some of the inflammation, learning how to move in a way that respects how strong you are so that you're not getting tendonitis by over ripping muscles apart, right? Um, Things like that. Working on the biomedical can be helpful, but there's so many other helpful tools. And just starting to get educated about danger messaging and pain as an output, one of our many outputs to incoming danger messaging. I'm talking about physical pain, I'm not talking about emotional pain, okay? All right, so learning to become educated in modern pain science. So make sure that you're starting to look for things that have been written since the 2000s. We don't want to start going back into that Cartesian model of pain, or like I think that John Sarno did an interesting job, but didn't have some of the tools to be able to understand the mechanisms of what he was dealing with and working with. So realizing that we're actually not at the mercy of our biomedical process, that we can change our biomedical process, but we also can change our sense of danger or safety in the world. Balancing danger and safety messages. That is an ongoing work, not just today, not just in the presence of a tendonitis, but every single day. I had this experience the other day where I thought I might have lost my wallet. And I had this moment where I was like, am I going to elevate this threat or am I going to keep this threat in check? And I was like, you know what? I'm just going to keep this threat in check because I've lost a wallet before. I know what it's like. I'll get there. There's not going to be any damage to my personhood. I can get through it. So, exploring the beliefs underlying our psychology and our sociology in addition to providing some wonderful biomedical support, I mean, that's like such a win-win situation. Using bioplasticity in our favor. So, understanding that if we have been habitually turning that volume knob up on our danger, we can selectively start to turn that knob down. And we don't want to turn it down so that we're never responding, but we want to choose to send that threat up when it's important and not when it's not important. Understanding how to access the medicine cabinet in our brain and body. We have some of the strongest pain relievers, endogenous opiates. They're like as strong as morphine. We have oxytocin, which is such a wonderful one, serotonin, dopamine. How do we access these things? If we are turning up the volume on our danger messaging, we cannot get into that beautiful medicine cabinet. So basically, like I was saying, we got ourselves into this situation. It's our friend or it's our foe, but it depends on what we're co-creating with our plasticity. Plasticity means changeability. And this is the biggest thing I think missing from current orthopedic practice is that we're not telling people like everything you want to change is capable of changing to some degree. We don't know how much, but it's capable of change. And in fact, if you think about it, everything's changing all the time anyway, right? Impermanence is a real deal thing. You can change your tendons, you can change the resiliency of your nervous system. Every tissue in your body is capable of this. And I always say this every day until the day you die to different degrees. Right? It's kind of hard to know. And your neurons are especially capable of change. And they're especially dynamic in this way because they are so well perfused with blood, right? The fascinating thing to me is when I see like nerve injuries that don't change that should have changed. All of us kind of are like scratching our head about it, but I think that this current model of pain science, the current model of how we use our nervous system, it's really important because when I've had people with seemingly changeable or modifiable nerve issues and they've said to me, this has happened and this is not going to change, then I know, oh, yeah, that's not changeable for that person because of the underlying belief structures. So that's why biomedical education is helpful. That's why it's a part of our practical strength stuff. And you can get stuck, your neurons can get stuck in this escalating pattern, but you can also unstick them. They don't have to stay stuck in that pattern. And I love this image because it's like for a lot of us, these kind of happy hormones like endorphins, endogenous opiates, serotonins, they get locked away by our habitual use of our danger messaging. So we really want to start to free them back up. And I think part of this is why like movement education in tandem with pain education is so helpful for people, because movement, we know, helps people access all of these three things, these really strong hormones and these really strong chemicals, and these balance out some of the effects, like the response from the immune system to escalate danger, right? So movement's really important, understanding pain's really important, understanding the flexibility of your nervous system is key in getting out of this work. And I don't know if you guys got a chance to see the Kenyan winners. For some reason, I just like cried when I saw this image. It was so beautiful. The Kenyan runners are absolutely spectacular. They just won, both of them won the marathon in LA just recently. They spend hours, hours just doing warm ups. I've seen their warm ups so that they're constantly reforming, reconditioning their patterns, their pathways, their muscles, tendons, bones, their neurons for building to that ability to sustain like all out for 2 hours, which is absolutely incredible to me. It's just so beautiful to watch them run. Um, these are some of the references that I pulled from. You guys will notice a lot of the information that I presented today came from Supercharged, which is part of the NOI group. I don't recommend this book unless you already get some of the other books, because it's at this like extremely intense level. But like some of the NOI group, their Explain Pain Handbook is really good. They have online courses in this stuff, and they have a lot of blog posts. If you're interested in the connection between more cognitive therapy or cognitive behavioral therapy and psychology and pain, I recommend Rachel Zoffness. She's a clinical psychologist. She's teaching at UCSF. In fact, she's totally updated the information on UCSF's pain website. I was so thrilled to see. And then you can go to YouTube and just check out some of these videos. I have some blog posts as well on my website. And then we're going to close out for the day. So thank you so much for joining me, you guys.